Opioids, they are like opium-like analgesics. They are natural and synthetic. They derive from papaver somniferum poppy plant. Two alkaloid groups are there: phenanthrene, which is analgesic, that includes morphine and codeine, and others are benzylisoquinoline. It is analgesic and it includes papaverine and noscapine. Classifications of opioids are its agonist: morphine, codeine, heroin, fentanyl. Partial agonists are pentazocine, buprenorphine. Antagonists are naloxone, naltrexone, and others are tramadol, which has effect on mu and noradrenaline and serotonin receptor. So morphine, it's a prototype, it's a pure agonist which will act on mu receptor. Now we'll be seeing we are inside the body. The patient is in severe visceral pain like intestinal, colic, or cancer pain. You're standing in the brain and spinal cord pain pathway and watching the morphine act. So there is tissue injury, inflammatory mediators are produced that will carry the pain signals and they will go via peripheral nerves to the spinal cord and to the brain, to the limbic system, which will cause emotional pain. Now the morphine enters and it binds to the mu, kappa, and delta receptors. Mu receptor will cause mu action will give analgesia and respiratory depression. Kappa will cause dysphoria. Delta will modulate the neurotransmission. And what will happen to pain? Morphine it will increase the pain threshold. म्हणजे पेन अनुभवण्याचं जे तुमचं लाईन आहे ती वाढेल, म्हणजे जास्त तुम्ही पेनला सहन करू शकाल. And it will decrease transmission in the spinal cord. It will decrease emotional suffering in the limbic system. And the patient says pain is there, but it's not hurting. त्रास तर आहे, पण ते दुखत नाही. Why it happens? Central action inhibits release of substance P, hyperpolarization of neuron, so pain signal will be blocked. Peripheral nerve, peripheral action. During inflammation, opioid receptors will increase in tissues. Immune cells will release endogenous opioids, so morphine can act locally at the inflamed site. Now, what are the central effects, the peripheral effects, and the tolerance dependence of morphine? We have to see. First of all, looking at the central effects. Analgesia, best for dull, continuous visceral pain, less effective in neuropathic pain. Euphoria due to limbic system activate झालाय. नंतर anxiety, distress reduce झालाय. Or dysphoria in some kappa receptor case. Sedation होतो, drowsiness, REM sleep is disturbed. Rapid eye movement, sleep is disturbed. Respiratory depression, मेड्युलावरती हे ड्रग काम करतं मॉर्फिन आणि CO2 सेन्सिटिव्हिटी कमी करतं, so patient becomes indifferent to breathing. Most common cause of death in overdose is respiratory depression. Meiosis stimulates, morphine stimulates third nerve nucleus आणि nitric oxide tolerance develops. So diagnostic sign, stimulates third nerve nucleus, no tolerance develop. Nausea, vomiting stimulates CTZ initially, more in ambulatory patients. Cough suppression works even at lower dose than analgesia. Peripheral effects, so आपण 7 सेंट्रल इफेक्ट्स बघितले: एनर्जेसिया, युफोरिया, सेडेशन, रेस्पिरेटरी डिप्रेशन, मिओसिस, नॉजिया, वॉमिटिंग आणि कफ सप्रेशन. सो सगळ्यात आधी कोणतं? एनर्जेसिया, युफोरिया, डिस्फोरिया इन कप्पा केस, देन रेस्पिरेटरी डिप्रेशन, सेडेशन, देन nausea, vomiting, cough suppression, and meiosis. Then peripheral effects on GIT, sphincter tone is increased, motility is decreased, there is severe constipation, no tolerance develops. No tolerance develops होतं. So meiosis stimulates third nerve nucleus and tolerance does not develop. Then biliary tract, pressure increases, avoid in gallstone pain. We don't have to give morphine in case of gallstone pain because it will increase the pressure in biliary tract. Urinary bladder sphincter constriction will occur, retention will be there. In CVS, mild effect will be there, high dose will cause hypotension, reduced stamina release. And so 4 are the peripheral effects on GIT, urinary system, then hypotension in CVS, and biliary tract. So GIT will be constipation, increased sphincter tone, motility less, constipation. Biliary tract we don't give it in the gallstone pain, and urinary bladder there will be retention, and in CVS it will cause hypotension. Tolerance develops to analgesia, euphoria, sedation, respiratory depression, but it does not develop to meiosis, constipation, convulsion, MCC. Meiosis, constipation, convulsion, tolerance does not develop to this. Due to receptor down regulation, increased cyclic AMP, the cell adapts. या सगळ्या गोष्टींना बॉडी टॉलरेट करू शकते, कारण की तिथं रिसेप्टर डाऊन रेग्युलेशन होतं आणि सायक्लिक एम्पी वाढल्यामुळे सेल अडॅप्ट होतो. पण या कंडिशन्समध्ये तसं नाही होत. डिपेंडन्स, फिजिकल डिपेंडन्स विड्रॉल झालं तर ऑपोजिट ऑफ मॉर्फिनचे इफेक्ट होतील: पेन, डायरिया, मिट्रियासिस, हायपरटेन्शन, पायलोरेक्शन, कोल्ड टर्की. नंतर सायकोलॉजिकल डिपेंडन्स, डोपामिन वाढतं, रिवॉर्ड पाथवे देतो ते मॉर्फिन आपल्याला, त्याच्यामुळे सायकोलॉजिकल डिपेंडन्स असतो. सो युअर इन अ वॉर्ड, कॅन्सर पेशंट इज क्राईंग इन पेन अँड इट इज बीन गिवन मॉर्फिन. 10 मिनिटानंतर काम आहे, स्टिल अवेअर ऑफ पेन बट नॉट डिस्ट्रेस्ड. Pupils at pinpoint, slight drowsiness is there. If overdose, slow breathing, coma, pinpoint pupils will be there, and you immediately give naloxone. Okay, so think of morphine as a painkiller that calms the mind, slows your breath, stops your gut, shrinks your pupil, and traps the patient into dependence. Why opioids are more effective in visceral pain than in neuropathic pain? Okay, morphine, how it is acting? Opioids, how are they acting? They go to the receptor, they will decrease the cyclic AMP, they will cause the neuronal, they will burst, they will lose the neuronal excitability will be lost. Okay, these are the conditions. The neurons will become less excitable, and it will be, the pain generation won't happen in these cases, transmission won't take place. But in neuropathic pain, what is happening? There is degeneration of the neuron, so already the neuron is degenerated, there is burning pain, and opioids won't go there and decrease the pain sensation. And in neuropathic pain, what we give capsaicins we give. Then why meiosis does not develop tolerance? Okay, tolerance means getting acquired, getting habitual to that particular thing. So why respiratory depression is dose dependent with analgesia? More the dose given, more will be the respiratory center suppression, and more the coma will be caused, the respiratory depression will be caused. Why opioids cause constipation but are used in diarrhea? So opioids, they increase the tone of the muscle, they reduce the motility, so that's why they cause constipation. But we use them in diarrhea because tolerance develops to those opioids, and the body reacts by down regulating the receptors and increasing the cyclic AMP. Okay, and the cellular adaptation takes place, and thus they can be used in diarrhea. Explain cold turkey withdrawal. Okay, I will have to see proper answers to them. Visceral pain is intestinal colic, cancer pain, deep organ pain. This pain is dull, continuous, emotionally distressing. Often it will act strongly on the spinal pain pathways and the limbic system. So patient says pain is there, but it is not bothering me. And what is neuropathic pain? It's trigeminal neuralgia, diabetic nephropathy, then nerve injury. The damaged nerve itself firing abnormally. Morphine mainly suppresses the nociceptive pain pathways and not the abnormal damaged nerve firing. Hence, it is less responsive to opioids. Opioids are more effective in visceral pain because they suppress nociceptive and affective pain pathways, whereas neuropathic pain arises from abnormal nerve firing and it's in response poorly. Why does meiosis not develop tolerance? Tolerance is basically adaptation to the drug. The drug can no more cause the effects that it was previously causing. So tolerance develops mostly to depressant effects. But meiosis is mediated through mu and kappa receptor stimulation of the third cranial nerve's nucleus. So basically there is a third cranial nerve and it has got the nucleus, and there are mu and kappa receptors. When they are stimulated, then it will cause meiosis. And this pathway does not adapt significantly with repeated opioid exposure. It does not show adaptation to this thing. So even addict taking huge morphine still has pinpoint pupils. Pinpoint pupil diagnostic clue of opioid overdose. Meiosis does not develop tolerance because the oculomotor parasympathetic pathway remains persistently stimulated without significant receptor adaptation. If there would have been receptor adaptation, the receptors there wouldn't have responded to the opioid stimulation and they would have caused mydriasis. But this is not taking place. Tolerance is not being developed. Why respiratory depression is dose dependent with analgesia? So imagine at the receptor level, both are mediated by mu receptors. Analgesia and respiratory depression. Analgesia by mu receptor, respiratory depression by also mu receptor in the medulla. So increased morphine dose, it will cause increased receptor activation and increased pain relief, but also it will cause respiratory depression. That's why more analgesia will give more respiratory suppression. Respiratory suppression is dose dependent with analgesia because both are mediated through mu receptor. The increasing opioid dose increases both simultaneously. Why opioids cause constipation but are also used in diarrhea? So let's go inside the intestine, and the morphine, it will cause increased sphincter tone. Food cannot move easily. When the sphincter tone is increased, the motility will be reduced and the food can't move easily. Peristalsis will slow down, and there will be decreased intestinal secretion, less water enters the lumen. So as a result, there will be constipation. The stool will be hardened, and nothing opposite. In diarrhea, what we need, the problem in diarrhea is fast movement, and there is excess secretion. And opioids do the opposite. They slow the gut. They reduce the water loss. So drugs like loperamide, diphenhydramine, they are used in diarrhea. Do you get this? Opioids cause constipation-like symptoms, and in diarrhea, what is there? There is excess gut motility and reduced water loss, and excess water loss is there. And the opioids are doing the opposite of it, loperamide and diphenhydramine. So opioids cause constipation by decreasing the motility and decreasing the secretion, and the same mechanism is therapeutically significant in diarrhea. What is cold turkey withdrawal? In one line, if I have to tell it what it is, it refers to the piloerection and autonomic overactivity that is caused by sudden cessation of opioids. Okay, so a patient has been taking opioids and he suddenly withdraws the taking opioids, and that withdrawal will cause piloerection and autonomic overactivity. And why is the piloerection happening? Body had adapted to suppression due to morphine, but suddenly no drug, then opposite reaction starts, and that is withdrawal syndrome. Its symptoms are pain. Opposite symptoms will start happening. Those are pain, diarrhea, hyperventilation, mydriasis, hypertension, piloerection, the goosebumps, and that is called as cold turkey. Why is it is named such? Because skin develops goosebumps and rough appearance that resembles a cold turkey bird skin. Okay, so it's a bird, and our skin resembles the bird skin, and its mechanism is to noradrenergic storm. So locus ceruleus, it becomes overactive. Where is locus ceruleus? Do you remember? On the floor of the fourth ventricle. Okay, and yeah, the noradrenergic storm will be there, and it will cause autonomic overactivity. So yeah. So serious effects we had seen, there will be hypotension, urine medulla where there is vasomotor center. Morphine, it will have minimal effect on normal dose, but on giving higher dose of morphine, there will be reduced BP, reduced heart rate, so postural hypotension and bradycardia. Why? Because histamine release is occurring. It will reduce the sympathetic tone, and it will make your blood vessels not very constrictive. And important, increase CO2, it will cause cerebral vasodilation and increase cranial pressure. So we have to avoid morphine in head injury patients. Always remember, morphine is not used by the neurosurgeons when they will handle the head injury patients. The cause is head injury is there, CO2 will be, vessels will be ruptured. Whatever CO2 is been accumulated, it has to find its way to go out of the body to get metabolized, and it will cause cerebral vasodilation, and it will increase the cranial pressure. So we don't give morphine in this case. Tolerance, neuronal adaptation. Morphine binds the receptor, decreases the cyclic MP, neurotransmitter release is decreased, and analgesia is there. After repeated use, neuron will say, I will adjust myself. किती पण opioid, किती पण morphine येऊ दे, मी काय आता तुम्हाला भाव देणार नाही. What neuron does? It increases the cyclic MP, receptor down regulation occurs, receptors आत धसून जातात, ते काम नाहीत करत, आणि ion channels adapt होतात, ते पण काम नाही करत, आणि this is cellular adaptation. As a result, same dose will cause less effects and it will need higher dose to act. What tolerance develops to analgesia, euphoria? म्हणजे आधी म्हणजे टॉलरन्स कशामध्ये येणार आहे? एनाल्जेसिया, युफोरिया, सेडेशन, रेस्पिरेटरी डिप्रेशन, या साऱ्या गोष्टी रिव्हर्स होणार आहे. म्हणजे आधी एनाल्जेसिया होत होता, ओव्हरडोस झाला तर तो पेन होणार. युफोरिया आधी होत होता, नंतर डिस्फोरिया होणार. सेडेशन आधी होत होतं, झोप लागत होती, पण आता पेशंट ओव्हर ॲक्टिव्ह राहणार मॉर्फिन जास्त झाल्यामुळे. आधी रेस्पिरेटरी डिप्रेशन होतं, पण आता हायपर व्हेंटिलेशन होणार. आणि टॉलरन्स डज नॉट डेव्हलप टू मिओसिस, कॉन्स्टिपेशन आणि कन्वर्जन. म्हणजे मॉर्फिन घेणाऱ्या पेशंटमध्ये सतत मिओसिस राहणार आहे, कॉन्स्टिपेशन दिसणार आहे, कन्वर्जन्स दिसणार आहे. टॉलरन्स टू रेस्पिरेटरी डिप्रेशन डेव्हलप स्लोली, सो ओव्हरडोस कॅन स्टील किल. आणि रेस्पिरेटरी डिप्रेशनचा जो टॉलरन्स आहे तो लगेच पेशंट हायपर व्हेंटिलेशनला लागणार, ते स्लोली राईज होणार आहे. त्याच्यामुळे इट कॅन स्टील किल द पेशंट. रेस्पिरेटरी डिप्रेशन कॅन स्टील किल द पेशंट. क्रॉस टॉलरन्स बिटवीन ड्रग्स ॲक्टिंग ऑन द सेम रिसेप्टर. एवढं मला कळलं नाही जाऊ दे. देन डिपेंडन्स. नाव न्यूरॉन बिकम्स डिपेंडेंट. टॉलरन्स झाला ॲडॅप्ट नाही पर्टिक्युलर आपला न्यूरॉन आहे ना, त्या मॉर्फिनचा जो युफोरिया जो आहे, त्याचा हॅपीनेसवाला जो इमोशन आहे, त्याच्यावरती बॉडी डिपेंड झाली आहे की मला मी मॉर्फिन घेणार आणि मॉर्फिन घेण्यानंतर मला युफोरिक फील व्हायचं आहे. आणि विदाउट मॉर्फिन सिस्टम वॉज ऑपोजिट, मला असं डिप्रेस्ड फील होणार. सो विड्रॉल ऑपोजिट ऑफ मॉर्फिनच्या सिम्पटम्स आहेत. मॉर्फिन इफेक्ट, एनर्जिसिया, विड्रॉल केल्यानंतर पेन, सेडेशन, एजिटेशन, मिओसिस, मिड्रियासिस, कॉन्स्टिपेशन, डायरिया. सिम्पटम्स पेन, हायपरव्हेंटिलेशन, डायरिया, हायपरटेन्शन, मिड्रियासिस, पायरेक्शन, कोल्ड टर्की. वाय विड्रॉल हॅपन्स? बिकॉज लोकल सिरियसमध्ये मॉर्फिन फायरिंग कमी होणार. ड्युरिंग विड्रॉल नॉरेड्रेनर्जिक स्टॉम असतो, जो एक्सेस नॉरेपिनेफ्रिन देणार सगळे सिम्पटम्स दाखवणार. सायकोलॉजिकल डिपेंडन्स, डोपामिन जास्त आहे, रिवॉर्ड पाथवे ॲक्टिवेट झाला आहे. पेशंट्स विल क्रेव द ड्रग. आणि न्यूनेट्समध्ये विड्रॉल अकर्स बट माइंडर आहे, स्लो मेटाबॉलिझम असतं त्यामुळे. मिसलेनियस इफेक्ट, हिस्टामिन रिलीजमुळे इचिंग, ब्रॉन्कोकन्स्ट्रिक्शन आहे. इम्युनोसप्रेशन, टी सेल फंक्शन कमी झाल्यामुळे इन्फेक्शनचे चान्स वाढणार. देन एंडोक्राइन इफेक्ट्स, हायपोथॅलॅमसमध्ये डोपामिन कमी आहे तर प्रोलॅक्टिन वाढेल, वी ऑलरेडी नो. डोपामिन प्रोलॅक्टिन इन्व्हर्सली प्रोपोर्शनल. आणि एडीएच रिलीज वाढणार. अँटी डायुरेटिक हॉर्मोन, डायुरेसिस होणार नाही, ॲब्झॉर्ब होणार. सो फायनल इंडिकेशन, फर्स्ट डोस दिल्यानंतर पेन रिलीफ आहे. युफोरिक आहे पेशंट. रिपीटेड यूजमुळे टॉलरन्स काही गोष्टींना डेव्हलप होतो. एमसीसी, मिओसिस, कॉन्स्टिपेशन आणि कन्वर्जनमध्ये टॉलरन्स डेव्हलप होत नाही. आणि टॉलरन्स झाल्यामुळे ड्रग वाढवावा लागतो आणि मग त्यानंतर डिपेंडन्स होतो. आणि जर अचानक मॉर्फिनला थांबवलं तर विड्रॉलचे सिम्पटम्स दिसतात. विड्रॉलचे सिम्पटम्स कोणते बघून घेतो हे सारे, पेन, एजिटेशन, मिड्रियासिस आणि डायरिया. ठीक आहे. सो ओपिओइड्स calm the brain first, then force the brain to adapt, and finally make the brain dependent on them. हे लास्ट क्वेश्चन इम्पॉर्टंट आहे. Opioids can cause reproductive dysfunction in chronic use, hormonal imbalance,